Good morning, and thank you for being invited to discuss a subject that is of real urgent public health concern as how to prevent the serious health risk and safety risk associated with bullying or mistreatment. As a disclosure, let me say that this presentation will focus on a hypothetical clinical case evaluated by a fictitious established pediatric practice in this area. Let's say that they have hypothetically 2,000 active patients from 0 to 18. This is a 14-year-old patient that is being seen for the first time at this office because of quote-unquote not feeling well, feeling tired, and missing school. There is a 2 weeks history of frequent absenteeism due to not feeling well, feeling tired with intermittent headaches and dizziness, and no other symptoms. For the last 3 or 4 months, she has been experiencing headaches, inattention, forgetfulness, and decline in her academic performance. By the way, let me know if I'm out of sync, because I put the computer down, so the laptop down. So just raise your hand if the slides and my speech are out of sync. At age 9, she had frequent vague abdominal pain and diarrhea and was diagnosed with irritable bowel syndrome. At age 11, she presented symptoms of what it was thought being fibromyalgia, and at that time she was treated with Motrin. Over the past 2.5 years, she has gained approximately 50 pounds. Last year, she had frequent headaches and dizziness and was diagnosed as having migraine headaches. She was born after normal pregnancy and delivery, had normal developmental milestones, and experienced frequent geographical moves due to father's job. There is a family history of hypertension, migraine headaches, ADHD, and diabetes. At examination, she appears to be tired and anxious. Her BMI is above the 95 percentile. She has some very borderline elevated systolic and diastolic and has correction for astigmatism. She has also some crowding of her teeth, mild speech articulation distortion, and a few acne papules on her forehead. All her laboratory tests were normal. She also had a negative mono test and PPD. Our colleagues in this practice have been very concerned about the evolving research evidence documenting the significant link of serious morbidity and safety risk with participation in bullying as a victim and or as a perpetrator. So all those 3 groups are affected. In this context, as a routine for the last year, they have attempted to ascertain whether their patients have been either bullied and or bullying others, as well as experiencing health or safety problems associated with this type of maltreatment. So at every visit or clinical encounter, they either provide the patient and parents with a standard questionnaire that I will show you in a second, and or they use the questionnaire as a guideline to hold a face-to-face anamnesis if time allows. Their questionnaire tells their patient that they are concerned about people getting physically or emotionally sick when they are being bullied or bullying others, and that's the reason why they will be asking some questions about bullying and health problems. And this may have to be adjusted according to the developmental stage of the child, of course. It goes on to define what is understood by bullying, with examples of physical form of bullying, as well as verbal, psychological, relational, or indirect form of bullying. It asks the patient whether he or she has been bullied and or bullied somebody else in the previous 2 months, and if the answer is positive to one or both of these questions, the patient is then asked, and the parents, to complete the rest of the questionnaire that tries to ascertain the social setting where the bullying is occurring, the types of forms of bullying, its frequency, With whom did the bullying interaction take place? It's not just in school. This happens in other settings. It happens in the homes, between siblings, and that's not sibling rivalry. Then the questionnaire tries to detect the occurrence of symptoms in the last 2 months, happening at least once a week, including feeling tired, headaches, stomach aches, dizziness, and backaches, and or suicidal plans or attempts, running away from home, physical fights, absenteeisms, and fears of going to school. The pediatrician assessing this patient preferred to use a questionnaire as a guide for face-to-face anamnesis, and one of the colleagues in this audience actually suggested that to me a few months ago, and I want to thank him for that input. Explaining the health concerns about bullying and the need to check with all patients about it. Goes on to ask the patient about her understanding about the concept of bullying. Then the pediatrician validates the patient's understanding and asks her if it's okay for him or her to add his or her understanding, so they are both in the same wavelength. Then the pediatrician proceeds to give examples of physical, verbal, and psychological mistreatment of bullying. That leads the patient to relate her own experience of being called dirty names, being made fun of her teeth and tone of voice, and having her cell phone stolen. This mistreatment has been happening for the last months, at lunchtime or in the locker room. It makes Jane feel very depressed, angry, wanting to hurt the bully. Actually, once she punched her on the face, hurting her badly. The patient doesn't want to report these incidents for fear of being called a snitch, and also because the school authorities don't do anything. She also recalls having once complained to the counselor. She was brought together with the perpetrator into the office so they could quote-unquote solve the problem. The patient was blamed for being angry. She feels that there is no conflict to resolve between her and the other student and wants to be left alone. Conflict resolution, unfortunately, is very much used throughout the country to resolve these problems. And you don't put a victim of rape or any other mistreatment together with the perpetrator to solve a conflict that doesn't exist there. She also witnessed her best friend being bullied by being called gay and stupid. It makes her feel very upset because it reminds her what they did to her, and she feels afraid that it will happen again. This patient is also being bullied by the same kid on Facebook, and emails about spreading rumors about her and calling her a quote-unquote fat slut has been happening. The patient also felt the urge of making fun of her perpetrator when she feels angry. So in turn, she has been a perpetrator too. In previous grades, she was teased for being shy, very thin, short, and wearing glasses. She also was told she was a loser and that she should kill herself. She told her parents, who reported to the principal, but soon it started again. In 4th and 5th grade, she was also hurt in school by being spanked by the teacher for getting upset and arguing with her. This happened while living in Arizona and Alabama. These are at random 2 states where spanking in the schools is enshrined in their code, in the state code, so it's a law. While asked about experiencing emotional or physical symptoms, she indicates that she feels depressed every afternoon when she comes back from school. It lasts until she goes to sleep, and it has been happening intermittently for the past 2 years. For the past 3 months, she has been getting easily angry, irritable, or upset almost every day. Almost every night, she falls asleep by midnight or later, and she wakes up at 3:30 for 20 minutes while worrying about things. Sometimes she's awaiting by awakened by nightmares. Every morning she feels tired and dizzy and has headaches and stomach aches at least once a week. Sometimes when depressed or angry, she thinks of killing herself. 2 months ago, she took a bunch of Tylenol without telling anybody. She was not thinking of killing herself at the time of this pediatric visit or in the previous 24 hours. She has thought of running away from home, but she did not do it. She has also been hit on her head during a physical fight by her peer, who always makes fun of her. She felt dizzy and thought of taking a bunch of Tylenol. She did not tell anybody because they don't do anything. For the previous month, she has been frequently absent from school and wanting to stay home. Every morning she feels nervous, afraid of getting into a fight, getting teased and made fun of, and feeling afraid of going to school. As for diagnosis, our colleagues evaluating these patients have entertained the possibility of other maltreatment syndrome by unspecified person. This is an offshoot of abuse or maltreatment disorders, leading to a possible mixed anxiety and depressive disorder and possible post-traumatic stress disorder. In addition, this patient has obesity, a mild acne, and malocclusion. So, what are the immediate goals for intervention and treatment here? First, to avert, to prevent present, ongoing, and future bullying to and from this patient. Then, to stabilize the patient's mood regulation, her sense of well-being, her sleeping cycle and rhythm, her appetite, her self-esteem, her impulsivity and potential aggression to others, her ability to attend school, her attention and learning process and ability to trust and feel comfortable in social interaction, and last but not least, help her to reduce weight. Towards these goals, the following objectives need to be met. The first and urgent consideration is to ensure a parental and medical reporting of bullying to school, so that can, and then followed by a mental health referral for evaluation and treatment if necessary. Now, it may not be easy to report bullying incidents, and it may take you a few sessions probably to help the parents and the child. The student may worry about being considered a snitch if bullying is reported and possible retaliation by perpetrators. Reporting of bullying may at times require some pediatric advice about its aim. The aim is to protect the health and safety of both the victim and the perpetrator, and is not to get the perpetrator in trouble. The students need to feel comfortable with the idea that reporting of bullying is not to get the perpetrator in trouble, but to procure the school's support and protection of the victim and the counseling of the perpetrator about the harm being inflicted. In Maryland, each county board of education has a policy by law based on a state model for reporting acts of bullying. This is since 2008. The next slides will show you, and it's available to you on the internet, is the links to download these forms that parents and students can use to report these bullyings. So you have for Montgomery County, that is in several languages, and from Prince George's County, and you have it for Frederick County and Howard County Public Schools, Calvert County, St. Mary's, and Charles County. I try to include all the areas that are in the jurisdiction in Maryland for Children's National Medical Center. This system of reporting does not address the significant morbidity affecting both the victim and the perpetrator, and does not advocate for school intervention. And as a matter of fact, one of the items that are being asked in these forms, that I tell the parents just to forget about it, is why is this child being bullied? And I just tell the parents, we don't know why, and I don't think it's very relevant. That's for statistics for the state, but it's a useless question. It can be significantly supported, this reporting, by a medical statement that highlights the patient's physical and emotional symptoms associated with bullying, while advocating for school intervention, counseling of the perpetrator. So in our hypothetical clinical case, the pediatrician provided the patient and her parents with a medical statement specially standardized for a situation like this, in which it is documented that this is a patient under this medical care, and she has been suffering from depression, irritability, anxiety, insomnia, and all the symptoms that she has, and that recently she has been experiencing frequent suicidal ideas and plans. Then the medical statement provides information about the different forms of bullying that this particular patient has been subjected for the past 6 months, as well as the physical aggression that she inflicted on others. And this is important, as we will point out in a minute. The medical statement has a standardized paragraph that always advocates for the patient's right to a physical and emotional safe school working environment. It also has a standardized recommendation that those who bully others should be counseled and sensitized about the serious health risks linked to bullying and advised to stop this type of behavior. This is short of telling them do not punish the perpetrator but help the perpetrator, who can also be presenting all this type of symptoms. Furthermore, it recommends that if the bullying behavior continues in spite of school intervention, it is advisable that the perpetrator should be referred to sources of health care to help ascertain and stabilize their biological, psychological, and social difficulties which may be leading to this type of bullying incidents. So it advocates for medical intervention of perpetrators. It finally indicates that the patient will be provided with medical care to alleviate her symptoms linked to being bullied, but at the same time, our patient Jane will also be helped to modulate her anger and impulsivity that may lead to her causing harm to others. Because otherwise the school says, well, what do you expect? She's doing this to the others. So we said, we will take care of her not hurting the others. Help us to protect our patient. This should facilitate the beginning of school intervention. Now, why did these pediatricians of this fictitious pediatric practice inquire about bullying? Because they have been previously made aware and sensitized about, in a conference like this, about the nature of bullying, its related morbidity, strategies for its prevention, detection, and treatment. And first of all, they have been given a definition, classical definition of what bullying is that you see here. This is what you can see in different laws, in research, and so on. I have some concerns with this definition on 2 points. Number one, in terms of the intentionality of the acts, as well as the need for this behavior to be done repeatedly in order to qualify with the definition of bullying. Allow me to explain briefly about these 2 points. First of all, if you have a patient that has Tourette or impulse control disorder, may without intention hurt somebody else physically or verbally, but there is no intentionality, but at the end of the day there is harm anyhow. Also, there is no need for a physical or verbal mistreatment to be repeated in order to cause harm. How many times does it need to happen in order for the other child to bleed or to hurt emotionally? Furthermore, the victim may have been bullied in the past, and one single episode of even unintentional mistreatment can be hurtful. Our colleagues were also made aware that bullying can be physical, verbal, or indirect, like rumors being spread about oneself or being ostracized. They were also explained that bullying is in the eye of the beholder, as previous bullying episodes may sensitize somebody to future incidents which may be experienced as mistreatment by the victim, even if they are not perceived as such by the others. But at the end of the day, another episode that may or not be bullying in itself, and we are splitting hairs there, may be experienced by the victim, especially if there is post-traumatic stress disorder, as a reenactment of previous episodes. Furthermore, clinicians need to be aware that the relevance of ascertaining whether the bullying occurred is only significant within a litigious kind of framework. And schools very frequently convert themselves in tribunals. Did it happen or didn't happen? Because somebody needs to be punished. The question of whether the alleged incident meets the criteria for bullying may not be relevant within a public health perspective, as the patient still is being hurt. Our colleagues examining Jane are aware that bullying occurs across different social settings, at home, in the neighborhood, in the internet, walking to and from school, on the school bus, at school, during and after school programs, in extracurricular activity, during religious services, school and programs, at summer camp, in dating relationships, in the workplace, and 30% of adolescents 16 and 17 are working part-time, during military training. Bullying can permeate and occur simultaneously across different social settings, and there is a suggested link between reported roles in school bullying and victimization in the workplace. While examining Jane, the pediatrician was aware that there are multiple factors associated with bullying, from height and weight to wearing glasses, from social anxiety, social relations, impairment to race, religion, nationality, or name. Therefore, it may be irrelevant to inquire about triggering factors. This line of inquiry could make the person who is bullied feel responsible for his or her victimization. It's important that the patient is obese to help her obesity in itself, but not to reduce bullying. The same with the crowded teeth, or her height, or or glasses. Our colleagues were aware that there is data showing that bullying is prevalent around the world, and this information is necessary only to be able to support the notion that bullying is a silent epidemic. Therefore, we should expect that it happens in all schools. We don't need to prove its occurrence by having preliminary epidemiological surveys to justify the development of a program. Based on national prevalence of bullying, our colleagues who examined Jane could estimate that 50% of adolescent active patients of this pediatric office may have been bullied and or bullied others in the previous 2 months. Furthermore, this pediatrician is aware of evolving research evidence supporting the urgent public health message that bullying is significantly linked to morbidity and mortality, as well as information that there have been hundreds of cases of death linked to bullying or hazing reported worldwide in the last 2 decades. These deaths have been due to suicide, homicide, or accidental injuries. Pediatricians at this office were aware of a study done at Children's Hospital where we ascertained the risk of physical and emotional symptoms associated with bullying based on 14,000 adolescents in the whole United States, and it showed that students who are either victims and or perpetrators are at significantly high risk of having a cluster of all these symptoms that we mentioned before, the headaches and the stomach aches and dizziness and depression. Other studies in Europe using similar methodology arrived to similar results. Participation in bullying also has been associated with being overweight or underweight, either preceding the victimization or as a consequence of that. Based on our study of morbidity associated with bullying, we can estimate that 32% of adolescents in this pediatric practice suffer from this combination of symptoms, out of which 62% of those have a history of participation in bullying. In a subsequent analysis, we found that students who participate in bullying behaviors are also a significant risk compared to the peers to have all this other morbidity. It has also been documented that adults who are bullied are at significant risk for cardiovascular disease, fibromyalgia, PTSD, alcohol, and drug abuse. There is reported international published evidence based on cross-sectional and longitudinal non-clinical population that participation in bullying is associated with suicidal attempts. Based on national rates of prevalence, we can estimate that almost 50% of the adolescents in this practice may participate in bullying. Around 38% of them suffer from these emotional and physical symptoms associated with it, and around 67 patients may hurt themselves on purpose in the course of the year. So finally, how can this be prevented? We should consider three-tier approach. In terms of primary prevention, The pediatricians can contribute by raising awareness about the nature and toxicity of bullying, advocating for the implementation of research-based whole school bullying prevention programs to create a positive and safe school working environment, programs that should foster sensitivity to others, mutual respect and peer support, with the inclusion of the whole community. This can only reduce the prevalence of bullying in 30 or 40%, 50% at the most. So it's extremely important, the secondary prevention that was illustrated in the case that pertains to routine detection, reporting, and requesting school intervention. That still may not be sufficient. That leads to the third tier, that is the treatment of morbidity associated with participation in bullying and treatment of the perpetrators. This is a whole community involvement, as you can see clockwise, supported by monitoring of prevalence and public policy. And last but not least, health professionals in this area can participate in the efforts of a coalition for the prevention of bullying that was launched 3 years ago. This is a partnership of different sectors of the community to raise public awareness about the nature and toxicity of bullying and advocate for the implementation of public policy and programs for the prevention of bullying. Thank you.